Okay, so basic physiology of asthma, criteria of reversibility. Increase in FEV1 by more than 12 percentage or more than 200 ml after 15 minutes of beta 2 agonist, inhaled one, or 2 to 4 weeks of prednisolone therapy. So 15 minutes after a beta agonist, 2 to 4 weeks after a steroid therapy, prednisolone. Okay, so that's the criteria of reversibility. That's the basic physiology. So, in order to diagnose asthma, the only thing, or maybe the sole thing, which is the most important, is demonstrating the reversible nature of the obstruction. So, it's going to involve the large and the small airways, and then it's going to respond better if it's case of extrinsic asthma than intrinsic asthma. All right. So, let's see the precipitants of asthma. Uh, okay. Precipitants, actually, there is a video. Just go see it. Apart from that, I'm just going to brush up. Mm, Allergens, example can be animal fur, pollen, dust mite. Drugs could be aspirin, NSAIDs, and beta blockers. Diurnal variation of symptoms or peak flow. Morning dipping of peak flow is common and can dip the balance into a serious attack despite having a normal peak flow at other times. Exercise, quantify the exercise tolerance. Acid reflux is known association with asthma. Okay, other atopic diseases, eczema, hay fever, allergy, or family history. Vitamin D deficiency also can predispose to development of asthma. SAM test triad, aspirin-associated asthma usually begins with perennial vasomotor rhinitis that is followed by hyperplastic rhinosinusitis with nasal polyposis. So those are the precipitants of asthma. Moving on to the pathogenesis. We already know the triple M, muscle hyperreactivity, mucosal inflammation, mucosal edema or swelling. Okay, pathogenesis we have state of persistent subacute inflammation of the small and the large airways. Cells which are involved are epithelial cells, mast cells, eosinophils, and lymphocytes. Just remember lemon. Okay, LEM. L for lymphocyte, E for eosinophil and epithelial cell, M for monocyte. Sorry, mast cell. Okay. Yeah, monocyte, mast cell. Yeah, fine, mast cell. Mediators, histamine, bradykinin, leukotrienes, DE, prostaglandins E2, F2 alpha, D2, and PAF, platelet aggregating factor, interleukin 3, 4, and 13. 3, 4, and 13. I thought it was 4, 5, and 13. I think it's 4, 5, and 13. Okay. Response, bronchoconstrictor, vascular congestion, edema formation, increased mucus production, and impaired mucociliary function. These are also associated features. Okay, so response on the okay, so there is a chronic, not chronic, there's a subacute inflammation of the large and the small airways. The lemon cells are involved. Mediators are histamine, prostaglandins, leukotrienes, bradykinins, platelet aggregating factor, interleukins. Okay, just remember bradykinin, histamine, leukotriene, interleukin, and platelet aggregating factor, prostaglandin. Okay, response on the bronchoconstriction, edema formation, vascular congestion, increased mucus production, and impaired mucociliary function. That was about the pathogens. Moving on to the pathology. The most striking pathologic feature in case of asthma is bronchial inflammation and occlusion of the bronchi and bronchioles by a thick tenacious mucus plug. Okay, so there will be thick tenacious mucus plug. These thick tenacious mucus plugs are going to obstruct the occlusion of the bronchi and the bronchioles. There are certain features of asthma. Okay, there are a good number of features of asthma. Chronic inflammatory disorder. Actually, there are 8. Asthma is a chronic inflammatory disorder, maybe subacute, but we can say chronic also, no problem. Hyperresponsiveness of the airways, airway epithelial shedding. So, okay, so what happens is it's a chronic inflammatory disorder. That's the umbrella term. Okay, so what happens is there is airways which are hyper responsive. Because they are hyper responsive, it's going to be shedding all the time. So there is airway epithelial shedding. After shedding, it has to heal, right? So there is subepithelial fibrosis and thickening of the basement membrane. So the epithelium is gone, subepithelium is undergoing fibrosis, the basement membrane is undergoing thickening. After that, what happens with the smooth muscle? The smooth muscle is undergoing hypertrophy and hyperplasia. Okay, hypertrophy, hyperplasia of the airway smooth muscle. Then blood vessels, microvascular leakage resulting in airway edema and plasma exudation at the airway lumen. Mucus hypersecretion, formation of the viscid mucus plugs that occlude the airways. Defects in the autonomic neural control. Okay, thank you.